because we are having one of the senior expertise in the field of left main and CTO intervention, Professor Dr. Chen Jin Wu from Taiwan. He's a professor in Chang'an Memorial Hospital and University. He has a tremendous publication in the field of left main, CTO, and IVAS.
So we have to under fluoroscopy to leave the J-tip 260 wire. Give me the step fluoro. So I'm taking out the 5 French sheaths and we load it with one of the VTK from Cook Company. That is 5 French, designing originally for carotid angio, but that was 125 centimeter long, so we can fit for 7 French guiding. That's kind of introduced because it's a taper end, so we can slip in the subcute. But before this, of course, we have a scissor cut in the subcute to make our entries more easier. So assistant have to keep this wire straight. Okay, keep traction. All right, aerial. Okay, focusing on my tip guiding. Come on, yes, yeah, right. So I'm pushing it. Okay, testing. All right, I'm just in. All right, we just try to stabilize that M+1 in the RCA orifice. You have a shaper? Do you have a shaper? So follow me. Testing. Testing. Okay, testing. All right, this is a PD. Exactly right. We are already in the PD. Okay, so some nitro. Cine, follow me to the RAT. Push. Okay. But it seems like we are not in the PD. PD is, yeah, should be. Pardon me. Okay, so yeah, test. 5,000 for each radio. Okay, so leave test please. Okay, test. All right, yeah, this is okay. I'm leave it here. Okay, so this one. Okay, Cine. Okay, you go first. All right, and I'm filling up here. And actually, not too long, huh? And probably you have a micro channel. So if we are lucky, we can go antegrade. Okay, moving to the target, please. Okay, yes, all right. Then you are spider. I want checking the spider to see if we can separate. Okay, yeah, first. Okay, feeding up, and I was connecting. Yes, that is breaching collateral. I'm trying to use a taper hydrophilic wire. This is 14,000 and taper into 9,000. So if they have micro channel in the CTO site, maybe we can try to probing. But I'm not too aggressive to push it, because I can see from the spiral projection they have a lot of breaching collateral communicating into distal part of the CTO. So this is not a true channel. For the spider bee, we have to aiming upward, instead of going lateral. That is bridging collateral. No, I don't know, focusing here, I'm only making a small curve. Fine cross is the smallest currently a micro caster.
Procedure you're doing, you rotate the guide wire and pushing the wire at the same time?
Yes, yes. Then we can check from the retrograde. Yeah, okay, you check from the retrograde. I'm not too aggressive because this is a soft wire. So I'm just try to puncture, to find the micro channel direction. But actually I'm deviate from the, so this is bridging collateral. You know, from the IO coil I have to move my wire tip upward, but it seems like it's continuing going down because they have total occlusion there. So we probably, so indicate might be no good micro channel. So we have to go retrograde instead of antegrade. Yeah, cine, some sedation. Okay. We go AP cranial. So we started retrograde, Because I'm working on the 100 centimeter guide, sometime I have 85, then we can use 130 long of the Corsair. And the Corsair actually was designing by Dr. Kato, who is the first man doing that retrograde card technique. The fine cross and Corsair, it seems it does not make difference, but you know, Japanese colleague, they like to use Corsair more instead of so I'm pushing here to my landing position. I remove my BMW wire so we can super selected injection and give me some contrast with 5 ml syringe. Okay, follow me. Actually, they have sabro septal. You can see that. So we can serving that each one of the septal is fine. So actually, the collateral is not going from the. This is like acute marginal and sharing some, supplying the PT. I don't know if you can give me a little bit test. Let's see if I can serving. Yes, okay. I can go through this angle. Yeah, it's somewhat difficult move. This is a quite big bend, but hopefully I can move. All right. So I'm now because the wire has some movement already. So in here I like to just gently rotate my caster, like a counterclockwise rotation. I can move. So the wire now is pushing into the LED now. So it's good start. So I'm rotating, continue rotating of my Corsair, and hopefully it can go straight up. Okay, straight up. It's pushing out. Okay, all right. So my guiding a little bit disengaged, so I have to push it back. Sorry for the patient. All right. So now we are at already reaching that distal cap.
That you have done to introduce this microcatheter into the lesion is to rotate And pushing.
Counterclockwise rotation.
Anti-clock.
Yeah, yeah.
And push.
Let it gently push.
And pushing.
Yeah,
okay.
push it. Yeah. Okay. So now I'm trying to probing with this Sion. I don't know if he's a channel or not. Okay. But it seems like we are in some channel. Test antegrade. Okay. So this is. So I'm a little bit deviates. I'm a little bit low. So from now on, I want to switch to, for example, hardwire. Yeah. So miracle tree.
Professor, how do you explain the passing the guide wire retrograde is easier to go to the LID rather than antegradely?
Usually easier then because
why is that?
The CTO cap usually harder in the proximal, but the distal is usually a little bit softer. So I would use somewhat not that harder, and especially if you have contralateral walking, if you have perforation, it would be somewhat difficult to stop the bleeding. So I would rely on more, the soft wire, and aiming that if I cannot go to the true lumen, and I can using wire as a marker, and I try maybe Miracle 6 go from antegrade. I'm removing my Sion wire. Now I'm replace it with Miracle 3. Okay. How come it's a lot of strong resistance? Spider view. Taking back of my course here. Okay, it's alright. I can have some space. Working on the. Retrograde, I feel so much strong resistance. Might be due to epicardia collateral, trapping my caster.
Usually go sudden upgrade from 3 to 12 or confianza?
No.
Or just gradual?
Gradual. So I can, I'm keeping this wire here. I'm trying to give me a Miracle 6. I need antegrade. Yeah. This is a CTO. Maybe it's not a straight portion here for some angulation. I feel it. So I need to have a second bend. Try to negotiate, but it's okay. I can see. Take out the. I can see they have a good connection. Yeah. This is extreme. So we take out the extreme. Miracle 6. And try to make it parallel to the retrograde wire. And if it's possible, we can do reverse cut. Keep that extreme because I need might be. Getting back up my. So that's not stable. Maybe EBU 4 is better. This might be. I'm feeling a strong resistance here. This is might be that CTO segment. Test please. can see the retrograde is actually touching that already some, but I feel is you have to make a turn. Yeah, touching. Yeah, but it seems like going here, then deviation. Walking now from the retrograde. This is sometimes we do. This is a knuckle, but I personally I don't like. No? I don't like knuckle because I like to. Yeah, yes, the extensive dissection. I don't like that knuckle. But here we feel some strong resistance because I get here. I have to turn. So maybe give me another miracle 6. Yeah, this is more close to the more. That is at least more. Yeah, we are almost like a kissing now. Yeah, this is maybe if we are lucky we can go through. Yeah, I'm through. Yeah, because I can go right in the true room now. Perfect. So don't need a retrograde wire. Okay, I'm taking out my corsair and we can inject through here to make sure this is a true lumen. Give me a contrast.
Your septal channels without complication, even or this epicardial channel without perforation.
Usually I would not too aggressive to advance. If I feel direction is incorrect, and I would just keep it. But I feel this is a true lumen now. Yeah, okay, yeah, I'm sure. Okay, so I'm taking out my, I just give me a run through original or some other BMW wire because I want to keep it in the corsair, in that epicardial collateral in case they have some complication happen. BMW?
So BMW now will replace the Miracle 6?
Yeah, I'm just keeping in the epicardial collateral to, at the end of the procedure, I want to make sure there are no complications. Otherwise, serving this kind of epicardial collateral will be dangerous. So I want to keep it, leaving my wire tip in the LAD apical portion until the final. And we can check, Yeah, now I'm taking out my Miracle 6 because steep wire, I don't want to keep it in the LAD apical portion. So I'm replacing my Miracle 6 Antegrade now become a soft wire. So we are almost done. Prepare that 2.0 mini track, 2.0 by 20. So this mini track. Okay, 2.0 by 20. Okay, all right. So watch me that, the tip. Right.
Dilate with the 2 by 20 balloon. Dr. Wu expected the balloon to cross the lesion as long as we have crossed the lesion before the fine cross caster.
Okay, yeah, all right.
Up
cross. 10, 16. So this is, all right, 16 done. All right. Okay. Okay, 16 again.
Important to mention that we have left the retrograde wire in one of the collaterals.
18.
We'll keep until we make
okay, done. So you can see the CTO segment actually was somewhat bent. So this is the difficult part because on this you have antegrade, have a retrograde wire guy. Okay, up 16. Concentrate here. Ibis next. Okay. All right, down. Okay. Okay, Cine. All right. Okay, we are good. Started some perforation at the CTO. I think might be that there's some spiral. That's because of some dissection, but it's fine. It's fine. Yeah. Ibis caster now is running from the mid portion of the LAD. I'm slowly pull back. And this is originally is patent, but we can see a lot of diffuse disease. The CTO has been there for more than 10 years. And this is a diagonal joining part. Okay, then the proximal is like a tree. So we can see the whole CTO track is in the true lumen. All right, this is perfect. Yeah, with the side and proximal trio and the mid portion maybe 2.5. Yeah, we are running. Okay, so the proximal part, yeah, should be trio. But yeah, this is element now. Okay, it's perfect. So we can dilate if it's 2.5 more. Yeah, 2.0. Okay, all right. They have one diagonal, right?
The size is 2.0, and then after reaching to the first branch, it came out 2.5.
Okay.
And then
ECT?
at 3.0, we have about 40 degree calcium with a 1, 2, 3.0 vessel size after the diagonal joint.
Yes.
Yeah.
Okay, yeah, up here. Here, all right. 6. Diffuse disease, yeah. So I might start it from here. 2.5, the longest stent, and we can edit it, but well, don't need to get to the LADOs, right? Okay, negative. So we like to start it standing from the second diagonal. Is that okay? 2.5, and the rest of the LAD should be fine. Okay. 2.5, 30. You order it? Yeah. What kind of stand? 32. Okay. Is promise element. Okay. Okay. Up. 10, 12, 14. Okay. 16. Is inside the stand. All right. Done. Yeah, maybe 32 is fine. Yeah, 3.0, 32. 3.0, 32. Yeah. Yeah, okay, up. 16. 16. Okay, 18. All right, perfect. Prepare the trio, high pressure. Quantum Maverick. Okay. Done. Yeah. I can. Yeah, we okay. 10 now. 10 now. 10. Okay, using a semblant to go again, not too high. Okay, done. This patient is doing fine. This is before nitro. So when I leave the diagonal.
Professor Wu, is there any rule for the glycoprotein to be 3
for
post?
the CTO?
Yeah.
For the CTO?
Yeah.
Usually CTO not that often to have a slow flow, no referral, unless you, as long as you're keeping the heparin in good therapeutic range. I think we can check IBUS now. Nitro 200. Okay, I'm moving in. All right. Okay. So I'm pulling back from the distal reference, and this is the instant now. 2.5. Audio is not recorded, right? But cameraman can record it. So 2.5 by 32 is the first promise element stance deployed from mid portion to the proximal. Then after that, we major it with the semblant and decided to go another 3.0 by 32 promise element again. Try to covering from the normal to the CTO segment. So now I'm splitting back of the Volcano. This is a newer version of Revolution caster. They have a marker in the tip, on the tip, and also they have a 45 megahertz resolution, so it's almost like a Boston caster. Okay. All right, and the tip also very soft. Okay, I'm now in the guiding. All right, perfect. Yeah, we don't have any complication. Even the course we have been passed through. Sometimes we go past. They have some complication, perforation or something. So we have to check all the way the course we pass. Then epicardias is sometimes it's dangerous. If you have any problem, we need to call you from each side. That happens. So we check another view. Area caudal and area cranial. Same simultaneous projection. Simultaneous injection. Okay, done. Perfect. Okay, move to the guiding. Move to the guiding. Okay, then we are focusing on more the apical. In case you can go down a little bit. Go down a little bit. Okay, here. All right. Then aerial. Okay, table up. Go more cranial. More cranial. More cranial. We can separate more. Okay. All right, now. Okay. So, sini, boss. Okay. All right. We are perfect. Okay. So, stop now. All right. Now we take out the corsair. I'm taking out the corsair and I'm disengaged now. Okay. Where now? So, what kind of hemostasis you want to use? Okay. Take the Bosch wire. Okay. All right. Compression. Okay. Chia Ben. Sorry. The patient might feel some arm spasm or something. Okay. All right.